If the disease was to progress here, we often divide these patients in Len refractory or Len sensitive buckets. This is where CARTITUDE-4 trial comes in, particularly for Len refractory patients. Bob, can you touch on the study design and some key findings from this trial?
Yeah, excellent study to point out here. We're excited about having B cell maturation antigen targeted therapies available earlier, especially following up on the maintenance discussion. If we're going to be using Dara and Len in combination for maintenance, it would be great to come in with a BCMA targeted therapy. Belantamab in combination with bortezomib and pomalidomide has shown some really good data. So that may be an area where if it's reapproved, which I think it will be, we'll be able to use that. And with the modified dosing regimens, the ocular toxicity has not been as significant. But definitely going after BCMA with a CAR T cell is another exciting way to go. This study looked at minimal residual disease in a comparison of Cilta-cel versus standard of care patients with Len refractory disease. The study was a one-to-one randomization where patients could get in the control arm either PVD, which is pomalidomide bortezomib dex, or Dara pomalidomide and dex as the control versus getting onto the Cilta-cel arm. And bridging was done with either PVD or DPD. Keep in mind that sometimes in these earlier patient populations, bridging may not be necessary because if you catch them early in relapse, you may not have as aggressive progression as later on in later lines of therapy. And the Cilta-cel definitely shows a much higher rate of MRD negativity. You can see the curves go up to roughly 90% versus not quite even 40% in the standard of care arm. And on the right in your bar graph, you're showing very nice data at 10 to the minus sixth, which for right now is the most sensitive that we can get on MRD testing. That's an 85% number versus about 18%, which is an incredible difference. You've got an odds ratio of 28.5. These are incredibly high MRD negative rates. We know that if you're MRD negative, especially at more than one time point, those are the people who do best in terms of progression-free survival and overall survival. There were a couple of nice abstracts at ASH talking about using mass spectroscopy on peripheral blood as an MRD assay. Hopefully that will be available to us soon. None of us are big fans of doing multiple bone marrows to send those off. If we could do it on peripheral blood, it would be more accessible to every patient and doctor, both in academia and in the community.
Yep. Just given the impressive results, Bob, was wondering outside a clinical trial, in what setting or what line are you utilizing CAR T for your patients?
I definitely send patients to BCMA targeted CAR T standard of care therapy in the second line setting. The people I particularly think about for that are folks with high risk disease at the molecular level, where the results with these CAR T and BCMA targeted therapies have been quite good, not so good for standard of care. People
Right.
with rapidly progressing disease, these are all folks to think about for that therapy.